All right, so this is going to be your week 9 musculoskeletal presentation. Since you're going to be off on Monday, I'm just going to record the whole thing, and you'll be responsible for listening to the whole thing. Okay, so for this slide, you're going to need to make sure that you are very comfortable in what is going on with the terminology. So circumduction, it's a circular manner motion that you're going to see primarily in the shoulders. Pronation, the palms are facing down. Supination, the palms are facing up. Flexion is a bending. Extension is a straightening. If you've got a hyperextension, it goes beyond the straight line. So sometimes you're going to see this. They might say a patient or a person is double jointed. Abduction, you're moving away from the midline of the body. Adduction, you are moving toward the midline of the body. If you have your internal or medial rotation, you are rotating toward the midline. Whereas your external or lateral rotation, you're rotating away from the midline. Dorsiflexion, your ankles or your toes are pointed up. With plantar flexion, your toes are pointed down. For inversion, you're looking at the foot and it turns inward so that the toes meet, the big toes meet, turning inward at the ankle. Whereas eversion, they're turning outward from the ankle or from the ankle. Protraction is a forward and parallel movement to the ground. You're going to see this primarily in the lower jaw. With retraction, it's backward and parallel to the ground. So again, that's going to be your a jaw movement. When you're taking a health history on a patient, there are some things, and this is something we've already talked about. So you should be very familiar with this. When you're looking at a health history, you're looking at the PMH or the past medical history. So you're going to be asking about questions about any chronic musculoskeletal problems, any previous problems. What about injuries, trauma, surgeries? What about medications? And is the patient a smoker? When we talk about surgeries, we can ask if the patient has had an arthroplasty. That's a joint replacement. So typically what you're going to see are knee replacements, hip replacements, not so common shoulder replacements. Hips and knees are usually the big ones. When we talk about a review of systems, we're going to talk about myalgia, which is muscle pain. We're going to talk about ostealgia, which is bone pain, which is different from arthralgia, which is a joint pain. Make sure that you know those medical terms. Changes in any muscle strength, and then what does the patient do to promote health in their for their muscles and bones, the musculoskeletal system. So you're going to be asking about do they exercise on a regular basis, or are they very sedentary? You're going to be asking about, are they taking any supplements, in particular calcium along with vitamin D. Calcium helps, or vitamin D helps to get more calcium into the bones. So you're going to be looking at that to make sure that the patient is doing that. Other things you're going to be asking about. So what about a functional assessment? Are there any limitations due to the musculoskeletal system when it comes to bathing, toileting, getting dressed, combing their hair, eating, mobility, even their ability to communicate? What kind of sports or hobbies do the patient have? What about work? What do they do for work? And do they use any mobility aids? So we're talking about crutches, canes, wheelchairs, things like that. When we start to do our medical musculoskeletal exam, you're going to do your screening exam. So this is your inspection and palpation of the joints. You're going to do this just like you do the skin, basically. So as you're looking at the chest, the neck, the arms and legs, you're going to be assessing the joints in that area. So that's your screening exam. If you're going to do a complete musculoskeletal exam, if their patients have some kind of a disease that is related to the musculoskeletal system, or if they have had any changes in their functional ability, we're going to do a complete musculoskeletal exam. Now, they're saying here that for a complete musculoskeletal exam, we're going to use the cephalocaudal approach. Okay, basically, that's medical terminology for a head-to-toe approach. We're going to be looking for symmetry when we're looking and examining the bones, the muscles, the joints. So again, symmetry is going to be very, very important when we're doing our exam. So when we do our overall inspection, we're going to be looking primarily at posture. We're going to see if there's anything noticeable about the patient that we can see related to their musculoskeletal system. When we look at the joints, we're going to be inspecting for color, swelling, any deformities, any masses. You can also, with the joints, we can palpate for heat, tenderness, and crepitus or crepitation, both the same thing. And basically what those are that little crackling sound, okay, when there's movement. Range of motion, ROM, we're going to be assessing active range of motion. There's a difference with active range of motion. This is when the patient moves the muscles, moves the joints, so that they can show you, the nurse, how much their range of motion is. Now, there is also something called passive range of motion, and this is when the patient doesn't do their motions by themselves. Whoever's coming in and examining the patient, they're the ones that are making the patient go through those muscles. A lot of times it's going to be your physical therapy people. And then when they were talking about muscle strength, we're going to be testing muscle strength against gravity and resistance. When we're testing muscles range of motion, you can see on this slide here, the top part, full range of motion versus partial range of motion. And so as a nurse, you're going to be aware of how much motion a joint has. So for example, a shoulder joint has a bigger range of motion because it is a ball and socket joint, as opposed to the elbow, which is a hinge joint, and it can only move in one direction. So you have to know what kind of joint it is, and really the only ball and socket joints are the hips and the shoulders. Everything else, with the exception of the spinal column, is pretty much a hinge joint, and it's just like a door, and it opens and closes, and that's it. When you are testing for muscle strength, now you're going to be looking at this little chart here. So when we say that a patient's muscle strength is 5 out of 5, we're saying that this is normal strength for that particular patient. When we're doing an overall assessment on our patient, we're going to be inspecting the skeleton by looking at the patient's posture primarily. You're going to be looking at the extremities, and again, symmetry when it comes to the extremities, the arms and the legs. You're looking for symmetry, you're looking for the size, you're going to see if there are any gross deformities. And when you're looking at symmetry, when you look at the picture on the bottom left, you're going to see, for example, on the left, the patient's all kind of out of whack. The shoulders are not level, the hips are not level, and the knees are not level. So there can be a lot of things that can cause that, but these are things that we need to note and pay attention to. We're also going to be looking not only for symmetry when it comes to the muscles, but also any muscle wasting, which you could see if, for example, a patient has had a stroke and they have hemiparesis, so they've got paralysis on, we'll say, their left side. Because they're not using that left side, their muscles will waste away. They're going to get smaller, and so you would need to note that. So when we're talking about the head, the neck, and the cervical spine, so again, we're going to be inspecting, we're going to be palpating the cervical spine and the TMJ, which we've already learned how to do. So when you're inspecting the neck, you can look to make sure that it's midline. You can also have the patient do some range of motion exercises. So you can have them go ear to shoulder, as you see in picture B. You can have them do flexion and extension, so that's the head goes down and then it goes back, and that's in picture A. In picture C, you can see that we're testing muscle strength, which we know is cranial nerve 11. When we're assessing the spinal column, again, you're just going to inspect the patient. So you're going to be looking at their back. You can look at them at posture. Okay. If you want to check posteriorly, you can do that. You can have the patient bend over at the waist, and you can kind of run your fingers down their spinal column to see if they have any sclerosis or if their spine is straight. If they've got lordosis or kyphosis, you're not going to necessarily feel that with having the patient bend over at the waist, but when you're inspecting their profile, you're going to look and see. You can also check their range of motion, so flexion, extension. You can do a lateral bend. You can do rotation and see what their range of motion is for the spinal column. When we talk about curvatures of the spine, they can move in basically three different ways. So scoliosis is when the spine is kind of in an S shape. Kyphosis, it's more bent over from the shoulder area, and you're going to see that more in patients who are elderly, in their 80s and 90s. You're going to see kyphosis. Lordosis, their lower back is it pokes out a bit much, and you'll see that commonly in women with advanced pregnancy because the body's trying to maintain its center of gravity, but you can see that in other conditions as well. When you're looking at scoliosis, they're calling it the lateral curvature because it kind of goes from side to side. There will be back pain. The hips and the shoulders are usually uneven, as you can see in that picture to the far left, where the left shoulder is higher than the right. Okay, the hips are usually level though. Okay, and there will be some asymmetry when we're looking at the ribs and the flank area. When you're talking about kyphosis, this can happen with injury, but mostly with age and or osteoporosis. And this kyphosis is more curvature of the thoracic spine. Now, your lordosis is an excessive inward curvature of the lumbar spine. It can occur with abdominal weakness. You'll see this a lot in ladies with advanced pregnancy, and also some neuromuscular diseases can also come up with or can produce lordosis. When we are talking about inspecting, palpating the shoulder areas, okay, there are some motions here. Please make sure that you know these. External rotation, as you can see, it's hands behind the head. Internal rotation, it's kind of like if you're in the military or know about different military terms, it's kind of a parade rest kind of position. And you can see on the pictures here what they are. When we talk about forward flexion and hyperextension, look at how the arms are moving. Okay, on that picture with forward flexion, the arms are kind of rotated straight up. in front of the patient, whereas hyperextension, they go towards the back. Abduction and adduction. So when you're talking about abduction and adduction, the way to remember that is adduction, ADD, adduction. You're adding to the center of the body. Whereas with abduction, you're going away from the midline of the body. So please make sure that you know these, okay? And when you are testing muscle strength of the shoulders, you're going to abduct, so you're moving away from the body against resistance. When we're inspecting and palpating the elbow joints, we're going to be doing this for abnormalities. You're checking range of motion. So you're checking flexion and extension of the elbows. You're also looking for supinating or pronating the hand. So when you look at these pictures, you can see the flexion and extension. You can see pronation and supination. This is when you're just basically, supination is when your hand is up this, and I think about it as holding a can of soup in your hand, and then pronation is just turned upside down, okay? You can check the strength of the biceps and the triceps by having them push or push against resistance so that you can check their muscle strength. When you're checking wrists and hands, so now you're going to be checking flexion and extension of the wrists and the fingers. So when you're doing this, it's a simple motion, and you can see here on the picture of the slide what it is. On the top, you're going to see flexion and extension of the wrist. At the bottom where it says D and E, this is flexion and extension of the fingers. When we talk about testing muscle grip strength, you're going to, as a nurse, you're going to offer 2 fingers to the patient. A lot of times we'll hold our hand up upside down like this and have the patient grab and squeeze as hard as they can. Don't do more than 2 fingers. All you need is 2. We're checking the hips. Please make sure, and the safest way to do this is going to have the patient lying down. Now, it can be done, some of these, with the patient standing up and holding on to something, but for our purposes, we want the patient to be lying down supine. So you're going to see hip flexion with the knee straight, flexion and extension, and then you can see hip flexion with the knee flexed. Both of them work. Having the patient lie down, we can check external and internal rotation of the hip joint by, as you see this picture here, picture C, the patient's lying down, they've got their one leg pulled up, and they're moving their knee from side to side. Then for abduction and adduction of the hip, again, the patient is lying down and they're strictly taking their whole leg and moving it away from the body and towards the body. You can also check for muscle strength by having the patient move their leg or their knee against resistance. We're checking legs and knees. Now, this one we can have the patient standing up, but make sure that they're holding on to something. So we're going to inspect and palpate the knee joints. We're also going to be checking to see if there's any accumulation in the knees, particularly if the patient is complaining of pain. You're going to assess range of motion of the knees with flexion and extension, and checking muscle strength. So you're checking the strength of the hamstrings with flexion and the quads with extension. One of the things that we need to check, especially if there's some kind of abnormality with the patient's gait or if they're complaining of back or knee pain, back pain or hip pain, sorry, is we need to check the length of their legs. So we're going to measure from the anterior iliac spine to the medial malleolus. Or that's if we suspect a congenital problem, a history of a fracture or tumor. When we are looking at the apparent leg length, now we're going to be measuring from the umbilicus to the medial malleolus. So for that, we're seeing maybe some scoliosis, some contractures, maybe some pelvic abnormalities. So make sure that you know how to measure these two different things. So when we're assessing the ankles and the feet, we're going to inspect and palpate the ankles and the toe joints. We're going to be assessing for range of motion. So we're going to be checking dorsiflexion and plantar extension or flexion of the feet, eversion and inversion of the ankles. We're going to look at flexion and extension of the toes, and they should be equal bilaterally. When we're testing muscle strength, we're going to be doing pedal pushes and pulls, or foot pushes and pulls. And you can see on the picture, basically, it's kind of like you're going to ask the patient to push on the gas pedal while you are providing resistance at the sole of their foot, and then you're going to ask them to dorsiflex while you're providing resistance on the top of their foot. We know that as patients age, we've talked about this, the body changes, and patients, especially in their 80s and 90s, they develop kyphosis. As you can see on that top picture there, that patient's got pretty significant kyphosis. You can see some of the changes in her body. You can notice that the arms are now longer than the trunk. That doesn't mean that the arms got longer. Those long bones in the arms and the legs, those stay the same size. It's the fact that the spine has compressed that makes it look like the arms are longer than the trunk. Bony prominences. So when we talk about bony prominences, we're talking about the bones that stick out more. So that's going to be elbows, shoulder blades, tailbone, knees, ankles, all these places and more are going to become more pronounced. They're going to be more easily seen. As our patients get older, we need to be more aware of the fact that they are at a higher risk for falls for a lot of different reasons. They are developing some problems with their mobility. They might be confused. They might have some musculoskeletal injuries, or they may be dehydrated. So we need to be very, very aware of this with our older patients. We know that falls is one of the biggest reasons for traumatic deaths in older patients. Once a patient gets older, if they do have a fall, they are at higher risk for another fall, and it will increase their morbidity and mortality because they've had previous falls. When a person falls, and you already know this, there can be musculoskeletal injuries, head traumas, and emotional stress, especially in our older patients when it comes to emotional stress, because a lot of times they can't get up and move around like they did before. Or maybe the injury that they sustained requires them now to walk with a cane or a walker. And so this limits the patient's independence, which can cause a lot of emotional distress. There are several different tests that can be used to check for balance and fall risk. So one of them is the TUG test, timed get up and go test. And what they're doing is they're measuring how long it takes for a person to get up out of a chair, walk 10 feet, turn around, get back, and sit down. If the patient takes longer than 12 seconds, they're generally considered a fall risk. When you look at your Tinetti balance and gait assessment, again, this assesses fall risk. So you can see the scale that's used there. Now, the Morse fall risk, this is the one that is used most commonly throughout the country and the world, actually. And it checks different things. If you notice, if their score is less than 25, they are at a higher or a lower risk for falls. 25 to 45, they're at a moderate risk for a fall, and greater than 45, they're at a high risk for a fall. So usually, like for example, the Morse fall scale it should be documented. It should be done every shift, or at least every 24 hours, depending on where you're working at. But in the hospital, generally once a shift, or if there's been a significant change in the patient's condition. So what kind of musculoskeletal or skeletal abnormalities might you see if you're working in the emergency room? Very oftentimes there could be a dislocation. So you look at that top, it looks like a young man's shoulder. Okay, completely dislocated. There's no contact between those two bones in the joint. Something happened and it moved the bone out of the socket. A subluxation. So it's kind of a partial dislocation. When the two bones in a joint are misaligned. They're not necessarily completely not touching. They're just not lined up properly. And if you look at that with that patient's knees here below the shoulder, you can see that there's definitely some misalignment going on there. And then contractures. Shortening of a muscle leading to limited range of motion. So when you look at these other two pictures, you can see, particularly the person on the top right, where they've got their hand kind of this way. Okay? That's a contracture. That's something that can't that happens over a long period of time because the muscles are not being used. So with this, you want to make sure, if you can, that your patient, if they can't move that themselves, that they're getting passive range of motion exercises from physical therapy or somebody else to try and prevent contractures. So when we talk about fractures, it is a partial or a complete break of a bone. Some of the things you're going to see, some of the signs and symptoms, and it depends on what kind of a break and how long before it's treated that you're going to see some of these symptoms. But some of the things that you may find: pain with movement, deformity, decreased range of motion, localized edema. If you suspect that the patient has a fracture somewhere, you really do need to get them x-rayed so that you can treat it. So when you look at these two pictures here on the right, where on the top one, that bone's sticking out. That's just nasty. Okay. But you see the bone is broken and it is sticking out of the leg. That is probably going to require surgery to fix and put back together. Okay. When you look at the picture below that x-ray, you can see how easy it would be for a bone to break and stick out of the skin. All you need is just a little pressure and a little twist, and that bone could be sticking right out. At the very top where it says types of bone fractures, please make sure that you know what they are, you know the descriptions, and you are familiar with them. You will see them. Okay, so this slide's got a lot of information on here, so make sure that you know this, okay? So anytime there's any kind of an injury, and we suspect maybe a neurovascular or musculoskeletal type problem, we're going to be checking for certain things. Okay, so you're going to do what's called a CMS check. CMS stands for circulatory motor, and sensory. So when you're doing a neurovascular assessment, you're doing CMS checks, and that stands for circulation, motor, and sensory checks. Anytime there's any kind of a wound, possible fracture, something like that, we need to be checking for compartment syndrome. So what compartment syndrome is basically is that there is an injury in there. We're going to say, for example, in the leg. And with that injury, the patient's, the fascia around the muscles and stuff, it didn't break. It still got its full integrity. But inside that fascia, the muscles, the nerves, the bones even are becoming compressed because there's an injury in there and it is swelling. But since it can't expand outward, the inside is going to compress, and that can lead to potentially like crushing the nerves, crushing the blood vessels. Not only that, it's extremely painful. So compartment syndrome is something that we really want to try and avoid. So we're going to be checking patients' pulses, okay? And if there's any question, we're going to check pulses distal to the area of injury. So when you look at this picture here on the bottom right, okay, you've got 2 feet. One of them looks like a pretty swollen up ankle, things like that. The best place to check for a pulse is going to be the dorsalis pedis pulse because it is distal to the area of injury. You're going to be checking for color. You're going to be checking for motor function. For example, is the patient able to wiggle those toes on that injured foot? Can they feel anything beyond the area of injury? So those toes, can the patient feel when you touch them? Is the patient experiencing any pain at the area of injury or below? And what temperature is that area of injury? Is it warm? Is it cold? Is it hot? Okay. Also, we're going to be checking capillary refill on the toes in this instance. Okay. So when we're talking about compartment syndrome or different types of injuries that can cause compartment syndrome, we need to be real careful with this. This is something that can happen pretty quickly. So let's talk about osteoporosis, and this is something that happens quite often to usually and primarily white postmenopausal females. Okay. What osteoporosis is basically is a loss of bone density caused by a lot of different things. Aging is one, the decline of estrogen post-menopause, and the relationship of the decline of estrogen to a calcium deficit. When we talk about signs and symptoms, one of them is the decreasing height of the individual vertebrae. So this is where the patient starts to get shorter from the pelvic area to the shoulders. The spinal processes, they get smaller. Usually not a lot of pain that develops when this happens, usually, but not always. Okay. Patients who have osteoporosis, their bones tend to get very, very brittle. A lot of times over time, as they get older, they will develop kyphosis. So one of the things that can be done to help prevent or reduce the problems caused by osteoporosis is to have the patient take a vitamin D and calcium supplements. Okay. And it was mentioned earlier that the vitamin D helps the calcium get into the bones. Another thing that can help prevent osteoporosis is impact exercises or weight-bearing exercises. And so, I mean, not necessarily, having this, your 80-year-old grandma go to the gym and start lifting weights, but even walking is considered an impact exercise or a weight-bearing exercise. So if you could get them to, get up and take a walk, even 20 or 30 minutes a day is going to be helpful to help prevent that patient from developing osteoporosis. Secondary prevention type things. So usually around the age of 50 or so, once menopause has happened, we like to recommend for our patients to go get a bone density scan. It's called a DEXA scan. And it's just kind of like an x-ray, but they look at the whole body and they can determine what the bone density is for that patient. So now we're going to talk about rheumatoid arthritis. We're going to be talking about different kinds of arthritis. So please make sure that it's very clear to you what kind of arthritis we're talking about, okay? So rheumatoid arthritis, it is a chronic autoimmune disease that causes inflammation of the connective tissue. What you're going to see, it is bilateral involvement. You're going to see pain, edema, stiffness. Chronic morning stiffness, it gets better with warmth and with movement. So patients go to sleep. As they're sleeping, their joints and stuff kind of all stiffen up. And as they get up in the morning and they start moving around, maybe they'll apply a little heat to their hands. We're going to say, for example, their movement becomes easier. There are different things that you're going to see, especially in the late stages of rheumatoid arthritis. So look at the picture on the bottom left. You can see a picture of a patient's hands. Look at the little picture above and to the left, the drawing, and they talk about the boutonniere deformity, they talk about ulnar deviation, and they talk about a swan neck deformity of the fingers. Please make sure that you know what those are. Those are points that are differentiating points when it comes to rheumatoid arthritis. So make sure that you know them. Osteoarthritis. This is something different. This is not rheumatoid arthritis. This is something different. So this osteoarthritis, it's a degenerative change in the articular cartilage due to stress or overuse. It can affect weight-bearing joints or those with repetitive movement. So with osteoarthritis, it's very possible to see somebody with osteoarthritis in their hands who maybe have during their jobs, during their careers when they were, working, doing a lot of typing, doing a lot of hairstylists, a lot of movements with their hands, nail techs, a lot of movements, repetitive movements with their hands. It's very likely that as they get older, they're going to be developing osteoarthritis. Okay. Now, osteoarthritis can be unilateral. It can be just on one side, usually not inflammatory. With the affected joints, there's going to be a brief morning stiffness, sorry. Again, once patient gets up and starts moving their hands, that usually eases up the stiffness. There can be bony protuberances, limited range of motion, and crepitus. Make sure that you know the difference between Bouchard's nodes and Heberden's nodes. So Heberden's nodes, those are in the distal interphalangeal joint. So look at the picture on the top left. Whereas Bouchard's, that's more proximal, that's closer to the hand. Heberden's are more distal. These nodes, they hard, non-tender. They do and can cause some deformity, some limitation of motion. All right, so for this slide, this is a great slide for you to be able to determine what the differences are between osteoarthritis and rheumatoid arthritis. When we talk about these differences, there's different causes. So when you look at rheumatoid arthritis, there's an inflammation around the joint area. The synovium gets inflamed, and that's what causes the deformities. Whereas with osteoarthritis, the cartilage goes away. So you end up with bone on top of bone. Okay, it's a degenerative disease. Rheumatoid arthritis is an autoimmune. So please make sure that you are very comfortable with the knowledge of the differences between osteoarthritis. So let's talk about gout. It is a type of arthritis. It's caused by an increase in serum uric acid. Acute gout, severe throbbing pain in the joint with redness. So when you look at the top two pictures, you can see gout of the knee. When you look at the foot, that's the joint below the big toe. You can see how that's all red. Usually gets pretty hot, extremely painful. It may, in the area of gout, develop tophi. So when you look at the bottom two pictures, you see those white lumpy things. Those are the tophi. Patients with gout can also develop kidney stones, and we can assess that by checking for CVA tenderness, costovertebral angle tenderness. Remember when we were doing the abdominal exam in the lab and we did that indirect percussion? That will help us to determine if the patient's having any CVA tenderness. Another problem that we need to be aware of is the carpal tunnel syndrome. So this happens when the median nerve gets compressed. The patient will experience burning, numbness, tingling in the hands. It can happen when the patient is performing the Fallon's test or the Tinel sign. So with the Fallon test, when you look at this slide on the left-hand side, you see the young man, he's got the backs of his hands together. His elbows are up straight, so they're level with the ground, okay? If when he's doing that, the patient experiences burning, numbness, or tingling in the hands, that is a positive sign for carpal tunnel syndrome. Also, another way to check for carpal tunnel is the Tinel sign, and you're going to, as the nurse, you're going to compress the median nerve. And if that patient experiences burning, numbness, or tingling in the hands, that is a sign, a positive sign for carpal tunnel syndrome. Okay, so I think for day one, this is going to be enough. So we will stop here for today. When you come back on your next lecture day, we'll pick up with the central nervous system and go from there. But for Monday, Labor Day, this will be the lecture you need to listen to. I will hand out just a short little quiz, just a little paper quiz to check and make sure that you actually listen to this, and we'll go from there. So I hope you guys have a great Labor Day weekend, and I'll see you next week.